Everyone, my name is Jada Habish, and today I will be presenting on potential therapeutic approaches to nasoplastic pain, specifically insights gained from the Reese-European-induced myalgia model. Nasoplastic pain is an emerging concept in pain research. It represents a complex and often misunderstood type of chronic pain that challenges traditional categories like nociceptive and neuropathic pain. Unlike these, nasoplastic pain arises from altered nociception without clear evidence of tissue damage or somatic system dysfunction. This complexity makes it difficult to treat effectively, and innovative approaches are urgently needed. In this presentation, I will cover the background of nasoplastic pain, detail the methods used in the study, highlight key findings on mechanisms and potential therapies, and discuss the broader implications for clinical practice. So let's dive in. Nasoplastic pain is a relatively new category of chronic pain, formally defined by the International Association for the Study of Pain. Unlike nociceptive pain caused by actual tissue damage or neuropathic pain resulting from nerve injury, nasoplastic pain arises due to changes in how the nervous system processes pain signals, what we call altered nociception. This means that patients experience pain without clear evidence of damage or disease. Examples of conditions classified as nasoplastic pain include fibromyalgia, irritable bowel syndrome, and nonspecific chronic low back pain. Among these, fibromyalgia is particularly significant. It affects 2 to 3% of the global population and is often characterized by widespread pain, fatigue, and cognitive difficulties. The impact on patients' quality of life is profound. However, current treatment options for nasoplastic pain are limited. This is where the Reese-European-induced myalgia, or RIM model, comes into play. By mimicking the key symptoms of fibromyalgia, the RIM model allows researchers to explore the mechanisms of nasoplastic pain and test potential therapies in a controlled preclinical setting. The main research question this study addresses is how can therapeutic approaches be developed to treat nasoplastic pain using insights from the Reese-European-induced myalgia model. The RIM model is particularly valuable because it replicates many of the characteristics of fibromyalgia, including widespread pain, comorbid depression, and sleep disturbances. By studying this model, researchers aim to uncover the underlying biochemical and physiological mechanisms that drive nasoplastic pain. The ultimate goal is to use these insights to develop effective therapies that improve clinical outcomes for patients suffering from these debilitating conditions. The RIM model is created using reserpine, which is a drug that depletes key monoamides such as serotonin, dopamine, and noradrenaline in the brain and central nervous system. This depletion leads to hypersensitivity and depressive-like behaviors, closely mimicking the symptoms of fibromyalgia. To evaluate the RIM model, researchers employ a combination of behavioral and biochemical assessments. For behavioral tests, the forced swim test is used to measure despair-like behaviors in rodents, which correlate with depressive symptoms in humans. Local motor activity tests assess physical function and overall activity levels. On the other hand, biochemical analysts focus on measuring neurotransmitter levels, oxidative stress markers like reactive oxygen species, and pro-inflammatory cytokines such as TNF-alpha and IL-1 beta. Together, these methods provide a comprehensive understanding of how reserpine-induced changes in the nervous system and muscles contribute to nasoplastic pain. The study identified several critical mechanisms underlying nasoplastic pain. First, in the central nervous system, monoamide levels such as serotonin and dopamine are significantly reduced. At the same time, excitatory neurotransmitters like glutamate are increased, creating an imbalance that sensitizes spinal cord neurons and amplifies pain signals. Oxidative and nitrosedative stress further exacerbate neuroinflammation and neuronal dysfunction. In the peripheral nervous system, upregulation of pronociceptive receptors such as TRPP TRPV1 lead to heightened sensitivity to pain. This is compounded by increased levels of inflammatory cytokines that sensitize nociceptors. Finally, in skeletal muscles, mitochondrial dysfunction and oxidative stress impair energy metabolism, contributing to pain and fatigue. These findings highlight how central, peripheral, and muscular factors are interconnected in nociplastic pain. Based on these mechanisms, several potential therapies have been identified. Pharmacological treatments include monoamide reuptake inhibitors like SNRI and SSRI, which enhance serotonin and norepinephrine availability to reduce pain perception. Receptor blockers like TRPV1 antagonists target peripheral pain signaling pathways. Also, natural compounds such as Coricrium and selenium show promise due to their antioxidant and anti-inflammatory properties. Coricrium, for instance, reduces pro-inflammatory cytokine release, while selenium restores redox balance and reduces oxidative stress. Non-pharmacological approaches also play a key role. Regular exercise has been shown to normalize neurotransmitter levels and reduce chronic pain behaviors in animal models. Electroacupuncture, on the other hand, modulates pain pathways and reduces neuroinflammation. Together, these findings suggest that a multifaceted treatment approach combining pharmacological and non-pharmacological strategies is most effective. This study provides several important implications. First, it underscores the value of the RIM model in understanding nociplastic pain mechanisms and testing therapies. By targeting multiple pathways such as oxidative stress, neuroinflammation, and receptor dysfunction, future treatments could be more effective and comprehensive. However, translating these findings to clinical practice requires further validation in human studies. It's crucial to ensure that the preclinical findings from the RIM model accurately reflects the complexities of human nociplastic pain. In conclusion, the RIM model represents a robust tool for both mechanistic exploration and therapeutic testing, addressing an unmet need in pain management. There are several important directions for further research. One major gap is the translation of finding from animal models to human patients. Studies must evaluate whether therapies effective in the RIM module produce similar benefits in clinical trials. Additionally, the long-term effects and safety of proposed treatments need to be investigated. Combining pharmacological and non-pharmacological therapies could be a promising approach, especially when tailored to individual patients. Personalized medicine strategies guided by a patient-specific pathophysiological profile might optimize treatment outcomes. Addressing these areas could significantly advance our ability to manage nociplastic pain.